So first, I'd like to identify and define what is an older adult. An older adult is someone who's 65 years of age and older. So what makes them vulnerable? It's really things that would make anyone vulnerable, but three things in particular: their health status, their cognitive status, and their social support. Okay, so if an older adult is chronically or acutely ill, they can be vulnerable. If they are physically or cognitively impaired, even mild cognitive impairment to severe. Fewer social connections, if they have had a recent or not so recent loss of a partner or a spouse, or if they don't have family living nearby, they can be vulnerable. They can also be financially challenged. If they're experiencing depression, will make them vulnerable, and the dying certainly are vulnerable. So we know from research, past research, there are certain characteristics of a vulnerable older adult. They tend to be 75 years of age or older, less educated, and we define that by less than a high school diploma, ethnic minorities, living in rural areas, visually and hearing impaired, and cognitively impaired. Okay? So please do not leave the Connelly Center this evening thinking that all older adults are vulnerable, because that's absolutely not the case. Several older adults are doing just fine and continue to do just fine. Okay, so please don't think that if you're 65 and older, you're automatically vulnerable. Not at all the case. Okay? Okay, so what are they vulnerable for? Very important is multiple chronic conditions, and that is defined as 2 or more diagnoses. Okay, and that's going to come up a little later, so I want to be sure we remember that. They're targeted for fraud often. Also very vulnerable for further decline if they are already in a compromised state. Depression. Depression exists very much among older adults, vulnerable older adults. They are vulnerable for abuse, both physical, emotional, and financial as well. They're also vulnerable for avoidable hospitalizations. And we know through prior research that when an older adult gets hospitalized, they are more likely to experience medical errors, death, reduced quality of life, and functional decline. We know that just 1 day in the hospital for an older adult reduces their functional status. That takes them some time to come back. So we want to try to avoid that if we can. So let's talk for a moment about multiple chronic conditions. The United States Census Bureau estimates the 65 and older population will increase from 13% to 20% in 2030. That is a huge jump. And I just read today that by 2050, it's estimated that the 65 and older population is going to double in this country. Some of our global neighbors are already there at 20%. So almost half of the current US population lives with at least one chronic illness, and that means people who are 18 years of age and older. So imagine as they age, they may get more and more chronic conditions, okay? Among Medicare beneficiaries, 60% have 2 or more. 37% suffer from 5 or more chronic illnesses. Imagine all those meds that go along with that, all of those diagnoses interacting with one another. And among 85 and older, 83% have multiple chronic conditions. That's a lot of older adults with multiple chronic conditions. And we're expecting this to only increase as our population ages. So, I would like to talk a little bit about my personal journey. And I left the hospital for home health, not necessarily for older adults. I really wanted to try home health. The autonomy of home health really intrigued me and was appealing to me. And I also come from a very big family myself, so I love families and family dynamics, whether they're good or not. I just find that fascinating. And I fell in love with this population, older adults who tend to be chronically ill. And I fell in love with home health. There's something very special about caring for someone in their home. It's where they often come to terms with their chronic illness and where they learn their new normal. So there's something very special about that. There's also with home health, it's never boring because you never know what you're walking into, for sure. So eventually I became a nurse manager of the office because it's all about impact for me. And I really loved caring for my patients in their home. And then I realized that if I become the nurse leader, I can help other nurses and impact their patients in a positive way. So shortly after I was the manager for some years, I became the private duty manager because we started a new entrepreneurial endeavor in the office where we started a private duty program. So that was really fun. And I feel like that took me to the next level. I want to point out the picture of the man and woman, and that other person in the picture is me. Not a word about the hair. I can't explain it. I don't know what to say other than I thought I looked good that day when I went out. But that is a patient who is now deceased, but I cared for Rose for a very long time in home health and got to know her family. And she will always hold a special place in my heart. So she is loving that she's in my presentation tonight, I'm sure. I also want to point out the other picture is Lillian Wald, and she is the mother of public health nursing. She is a true nurse innovator. She is no more educated than all of you in this room, and she's pretty amazing. She actually started, she's the founder of the Henry Street Settlement, which today is known as the Visiting Nurse Service of New York. And many of you know that I have a relationship with the VNS. So I've always been intrigued by Lillian and wanted to be sure she was represented here today. So these are some of my favorite home health pictures. No, I am not in any of these because these are from 1918. But the first picture is a picture from the VNA of Greater Philadelphia. And I just love their matching hats and all of their coats and how they all look like they're ready to go. The other two pictures are from the VNS of New York. Notice they all have their bags, and some of them are wearing capes, and they're all set and ready to go. And here we are moving on to World War II. And you can see that there's home health nurses caring for moms and babies in their homes and children. And there is a very serious looking nurse who is ready to go see what her patient is up to. So here we are, we have some unique modes of transportation, even for home health nurses. She's riding her bike. There's another nurse walking the streets of the Bronx, making her visit, taking the subway with New York's finest graffiti in tow. And that upper picture was actually taken 2 years ago during the blizzard. So it's amazing to me the length that nurses in general, specifically home health nurses, will go to, as well as the heights. This is a visiting nurse climbing the rooftops of New York City. And I would love to meet this nurse. I'd love to know the backstory, but I do not. So it's amazing to me that she's climbing over the rooftops to see her patients. So the more comfortable you become with your nursing skills, the more invested you become in your chosen area, the more you will ask why. So you begin to see the issues and the problems, and you really want to help your population. And that's exactly what happened to me. I began to ask, why are we doing it this way? Why are my patients being hospitalized when I know I could have prevented it if I could have stayed in the home? So because of Medicare policies, sometimes we need to discharge patients from home health, even though as a nurse, I know that if I could stay in that home maybe every other week, I could keep them out of the hospital. But I'm forced to discharge. So I knew that things could be better. I really did, and I absolutely love this population. So I left home health, and I started my own consulting firm in home health. And I attempted to tackle these issues through quality improvement. And quality improvement is a process that many industries use, not just home health and not just healthcare, where it's very systematic, and Medicare requires, even if it's a good home health agency, that we are constantly trying to improve patient outcomes. So we saw a return on our efforts. It was very satisfying, so exciting to meet people I would have never met normally. And we were changing patients' lives one home health agency at a time. Again, I realized I could impact an entire agency's patients in a positive way. This is where I really learned how to work within an interprofessional team. There was every discipline had to be present, as well as management and oftentimes owners of agencies. So I really learned team skills. So one day, the University of Pennsylvania School of Nursing hired me, to conduct a research study. So that was pretty exciting because I did not have a lot of exposure to research. So I stand before you, honestly, one of the least likely people to earn a PhD. I had little to no exposure, as I said, in undergrad. The National Institute for Nursing Research, fondly referred to as the NINR, became public law in 1993. I was already finished school. I finished in 1992. I couldn't even spell the NINR. I had no idea what it was. And I don't say that to make fun of myself, but I want you to think about, I was once in your shoes. I did not like research. My only exposure to research was to have to memorize all of the nursing theorists, Hildegard Peplau, Sister Callista Roy, Dorothea Orem, people you probably have never heard of. But that was my only exposure, and I have been quoted to say to my roommate, who never lets me live it down, that I will never work in research. And guess I know you know what I do now. But I had said, what does research have to do with nursing? And the answer is everything. It is the crux of our profession. It is how we improve caring for patients and their outcomes. So I took this position with Dr. Kathy Bowles, who's in that picture. Don't say a word about the hair, because that was 2 weeks ago. So that's my real hair. So this was a telehealth study, and she needed somebody who had a lot of home health operations experience, which I did. So I worked with her for about a year, and we became very good friends. And she took me to lunch, and I should have known when she took me to lunch. And she invited me to get a PhD. And instead of saying, thank you, that is such an amazing opportunity, I laughed, and I told her she was crazy. I wasn't ready. And I said, I have little kids. I don't even think my youngest was in preschool yet. I said, no, that's not for me. I'll just run your study for you. So about a year later, she asked me again. And I had learned, again, about impact. I had learned that if I conducted research, I could have an impact on the nation's older adults. Globally, I could have an impact. So I was so lucky to have the opportunity to work under Kathy Bowles at Penn and Mary Naylor, both of whom are Villanova alum. So it was pretty exciting and an amazing opportunity for me. Okay, so I'm going to hope this works. This is going to be a big slide, so it may be slow. Each of your professors here at the Fitzpatrick College of Nursing are fighting for a population that they love. And we do not fight with fire and torches and fists. We fight with our ambition, with our persistence, and with our words. Through our scholarly writing, through our posters and paper presentations, and through our research grants. So here on faculty, we have Parkinson's disease represented by Professor Ellis and Professor Hickey. This is where it's slow, and I apologize. We have pediatrics, lots of professors looking at children. Dr. Cantrell, Dr. Dowdell, Dr. Hallowell, Dr. Yost, Dr. Weingarten, Dr. Kelly. An amazing group of people. Cancer. Dr. Burrell, Dr. McKenzie, and Dr. Pat Bradley, who will show up momentarily. Okay. Finally, we look at veterans. We study veterans and fight for veterans. Dr. Helene Moriarty. Disabilities. Dr. Suzanne Smeltzer. Come on, Suzanne. There she is. Okay. Nursing education, highly covered topic in the Fitzpatrick College of Nursing. We have Dr. Mariani, Dr. Ross, Dr. Jim Mendez, Dr. Nancy Schartz-Hopko, Dr. Evie Longetti, and Dr. Terry Capriati. Fan favorite. Marginalized and ethnic populations as well we fight for. Dr. Linda Capel, Dr. Linda Maldonado, Dr. Bing Bing Chi, and Professor Elizabeth Pettit-Damage, all working very hard. We have moms and babies and nutrition. We have nutrition with Dr. Oliver and moms with Dr. Amy McKeever. There they are. And finally, we have nurse work environment. Studied by our very own dean, who has worked very hard for many years to impact the environment all of you are working in or will work in. That's pretty amazing. Please know that every professor is not presented here, otherwise you would have seen how much even slower it would have been. So to start my research journey, I had to figure out what makes older adults at risk for hospitalization or vulnerable for hospitalization. Because remember, this was my big why question when I was working in the field in home health. And I'm not going to read all those things to you because you've probably experienced them yourself in your clinical areas. They have a lot of diagnoses, if they're taking a lot of meds, if they're not adhering to their prescribed regime. Okay, certain diagnoses make people more at risk for hospitalization. But I want to highlight to you that bottom last one in blue, and that is malnutrition. And the reason why I want to highlight that is because I learned about malnutrition and the relationship with hospitalization through an undergrad student here at Villanova, Carolyn Astrup. I'm so thrilled that she was a Davis Summer Scholar here, and she and I worked together, and we did a lit review and found out about malnutrition. So that's Carolyn. Carolyn graduated in May. She's very happy in San Diego working as a registered nurse, so I'm just so thrilled for her, and was so thrilled to include her. So to talk a little bit about my research now. So in 2000, Medicare instituted the Home Health Prospective Payment System, which what it did was it reduced the number of nursing visits that home health patients received, as well as the time that they could spend in home health. So in the Wall Street Journal, in all of the letters to Congress from Medicare, hospitalization kept flashing and flashing. Medicare was becoming very unhappy with how many hospitalizations that were occurring among older adults. And of course, nurses in home health had known this for years, but it was becoming a national problem. So when I was looking for my dissertation, I thought, I really want to look at how home health, number of visits, and length of stay impacts hospitalization. So what we did was we examined the relationship between home health length of stay and hospitalization and death, and also the number of nursing visits and hospitalization and death. We looked at 5 Medicare-owned national data sets. Over 31,000 people were in this data set. And I was so happy to have funding from the National Institute of Health, NINR. I learned how to spell it at this point. So, and I was so grateful for their funding, as well as the John A. Hartford Foundation. Really thrilled to have their support. So we found that people who did not have a long enough length of stay, and the minimum was 3 weeks, which really isn't that long, had more hospitalizations, were hospitalized faster, and also died faster. Similar findings with number of nursing visits. If they didn't get a set number of nursing visits, really 3, which is not very many, they were being hospitalized more often, and they were also dying. So this work really piqued our interest at looking at the timing of home health discharge. And I started to think to myself, how do we decide? How do we decide when people are ready for discharge? And the bottom line is it's individual clinician judgment. So imagine all of these home health agencies in the country, all of those therapists and nurses that are deciding on when patients are ready for discharge, it's all up to the individual. Everybody has different judgment. Everybody has a different opinion. And that's a problem. So the headlines started to change a little bit, and Medicare was now penalizing hospitals. If an older adult was admitted to the hospital and discharged, if they were readmitted within 30 days for whatever reason, as long as it wasn't planned, that second hospitalization was not reimbursed. So hospitals were becoming very nervous and very interested in partnering with community organizations to try to keep these older adults from going back into the hospital. So we shifted our attention a little bit to something called front loading. And front loading is defined as providing 60% of visits in the first 2 weeks of home health. So it allows clinicians to pick up issues earlier, to follow up on teaching that was started in the hospital, and to also hopefully help avoid hospitalization, which totally makes sense. Now, front loading came into being because of one study that was conducted, and it was a very small study, that found that if they front-loaded visits, they could keep heart failure patients out of the hospital. It did not work for diabetics, and that was the only 2 populations. So home health, because we have very little evidence in home health, there's very little research at this time going on, home health agencies ran with it, and they incorporated it across the board for all patients, regardless of diagnoses. So because home health was becoming extremely even more popular during this time, I wondered, did front-loading work? So we took a look. So the problem was that front-loading was instituted across the board throughout the country with very little evidence behind it. But something that was interesting, that even though patients were being front-loaded, 10% of home health patients are readmitted within the first 14 days. That's a lot. 58% are readmitted within the first 28. That's a ton of people. So we still have a problem. Front loading must not be working. So I wanted to find out. So what we did was we compared patients, we compared the hospitalization rates of patients who were front loaded in home health versus those that were not. We again used 4 Medicare-owned national data sets. We had 4,500 people. So happy to have my postdoc funding. I was in a postdoc fellowship at this point, as well as Sigma Theta Tau support that year. It didn't work. It did not keep people out of the hospital. So it was really ineffective. It was totally ineffective. Also during this time, I caught a lucky break. And the Visiting Nurse Service of New York was also interested in front loading. So they invited me to be a part of their team. I was not a co-investigator, but I was on the team. And they also conducted a front-loading study using a national Medicare data set, but a different year. So it wasn't the same data that I used, but their findings were similar. It didn't work. So of course I was like, oh, thank God. But they had a second arm to their study, and they also looked at early physician follow-up. And that means they looked at front-loading alone, and then they looked at if patients were seen by their physician within that first week of coming out of the hospital, did that keep them out of the hospital? That didn't work either. But something interesting, when they combined the interventions, meaning front-loading and seeing your physician within that first week, it worked. It significantly reduced hospitalization among these older adults. So to me, what that says is intercollaboration in caring for older adults is critical, is key. Okay. So I turned my attention back to our decision support work, into our how do we decide when patients are ready for home health discharge. And I was so very happy to be the inaugural recipient of the Eugenie and Joseph Doyle Research Partnership Fund, which was in collaboration with the Home Health Research and Policy Institute at the VNS of New York. So the VNS of New York is the largest home health agency in the country and the only research institute in home health in the world. So I was so excited to get this funding, and we wanted to talk to clinicians and find out, what do they look for when they're getting ready to discharge someone? Because no one's ever asked before. So we took it to the streets, and we had so much fun doing this study. We traipsed around New York interviewing 32 home health clinicians, interprofessional home health clinicians, to get their knowledge, to get them to tell us, what do you look for in discharging a patient from home health? We interviewed nurses, physical, occupational, and speech therapists, social workers, physicians, and home health managers, supervisors. We did a qualitative study. The qualitative analysis revealed 5 themes, and these are themes that are probably going to ring true for you, what you would think you'd find. Patient safety was paramount for these clinicians. They had to make sure people were safe, having a long-term plan in place, reaching the patient's maximum self-care potential, whatever that is, presence of a willing and able caregiver, and certain patient attributes that they look for before discharging. So this study improved our understanding of what interprofessional home health clinicians look for before discharging. But this was very important to me personally, because after these focus groups ended and we were kind of cleaning up our materials and grabbing a cup of coffee, I can't tell you how many clinicians came up to me and said, we need this. You are on the right track. This will really help us. And it was totally unsolicited. So it made me feel like, all right, we need to keep going with this. This is something good. So it really is a great motivator for me. Next study was a mixed method study. And those of you that have already taken your research course will understand that this means that we did a quantitative arm and a qualitative arm. Okay, so we analyzed the OASIS, and the OASIS is the required assessment tool in home health. And we also that was the quantitative side, and we also did interviews of home health patients and their caregivers to ask them, how did you know you were ready for discharge? What do you think we need to consider before discharging someone from home health? So the quantitative side was 4 national data sets, again, Medicare-owned, different data sets. We had almost 57,000 people in this study. So when you think of big data, this is big data. We interviewed 18 patients and 5 caregivers. both at Mainline Health, Home Care and Hospice, as well as the Visiting Nurse Service of New York. So we could get a very diverse sample. Again, I was so grateful for Hartford's funding for this study. So we found 9 themes, and I'm not going to read them because I'm going to go through them briefly in the next few slides. Excuse me. So this study was critical in helping us learn that the OASIS did not work. The OASIS did not help us at all in determining readiness for discharge. And I was really disappointed. But sometimes in research, you don't know what you're going to find. And you might be surprised by the results. So initially, I was really disappointed and thought, wow, this is a huge setback for me. When in reality, it was a setup. Because now we are going to develop and have been trying to develop our own evidence-based discharge decision tool. And it was so exciting that we had the stakeholders, the end beneficiaries of this tool, patients and caregivers, included in this study. So that was really wonderful. And this paper is in progress. I'm so excited that we have 4 Villanova faculty working on this paper, including myself. We also have a first-year doctoral student, Patty Griffith, working with us. We have 2 amazing undergrad seniors, Maeve Kenny and Erin Donnelly, working with us. Mary Beth Hoban is our clinical partner at Mainline Home Health and Hospice. And lastly, that's Dr. Kathy Bowles, who is and continues to be my mentor. So, self-care ability. Being able to care for oneself was really important to older adults and their caregivers. And it's highlighted by this quote. I think there are a lot of seniors who are depressed. It would impact whether or not they're going to take care of themselves. That was amazing to me that they were able to make that connection. Because when I started this study, I wasn't sure if they would really understand what I was asking them. Would they understand what I meant by, are you ready for discharge? And they got it. They may not have understood quite about the discharge decision support tool, but they understood what we were asking. Next is functional status. So getting around was really critical for older adults and their caregivers. And this patient said, the PT, she told me I was doing everything I needed to do. I was able. I was progressively getting stronger. You know, could I control my hygiene? Could I shower? Could I shave? Could I, all those important things? And keep in mind, with qualitative research, you don't change the quotes. So that's exactly what they said verbatim. Status of conditions. So even within your own practice, is the condition stable? Is their blood sugar stable? Is their blood pressure stable? And they could understand number of diagnoses and whether they were stable or not had an impact on whether they should be discharged or not. So this patient says the sugar levels started spinning out of control because, the operation knocked off the whole regulating system in the body, but then blood pressure became a key concern. So this patient knew that he went into home health for his blood sugar, but then ended up having an issue with blood pressure. So couldn't be discharged until that issue resolved. Very astute patients. Adherence to the prescribed regime. They acknowledged that they didn't always pay attention and do what they were supposed to do, but they knew that they should. So this patient, I realized the importance of doing exactly, when you're dealing with a neurological issue, you really have to listen carefully to the clinicians or you're not going to have a good outcome. I was really blown away by what these patients knew. Safety needs. They went through to the bathroom, checking and seeing if it was convenient for me. Whether I could slip and hurt myself. They knew that presence of a caregiver was very important. For somebody who doesn't live alone, maybe they ought to ask questions to the caregivers there. Hey, have you seen any change in their behavior? Just so they could let you guys know. They also knew that support for the caregiver was very important. There are stressors that we really should think about to make sure that you have someone. If you don't have a caregiver, if something happens to your caregiver, you're not doing your patient any good. So we are nurses. We take care of everyone. The caregiver perhaps is not our patient per se, but we have to take care of our caregivers, especially in the home, because they are there. Connection to community resources and supports. One of the things that I think that, in my experience anyway, as I was to connect people with agencies that did some of this other stuff. Not that they have to do it themselves, but they should really be aware of what is available to that person. And finally, care coordination. Patients and caregivers did not call it that, but that's exactly what they were talking about. So this patient made me laugh, and she said, she writes to him on the computer thing. Whatever, email. My most favorite, if I've got to see 5 different people, that's really uncomfortable. I don't want to have to tell you and you and you, like, don't you all sit and talk to each other? And I was like, no, we don't. We don't. Sadly, we don't, but we need to. So in summary, the interprofessional home health team plays a critical role in discharging patients from home health to self-care. Patients and caregivers were very astute at identifying what to consider before home health discharge, and the findings between the two were amazingly similar. That's why I didn't go through the first study, all of those themes. It's pretty amazing and pretty validating. So we are using both of these studies to help us think about all of the factors that need to be in our discharge decision support tool that we are creating. We will provide care to those who need it to avoid hospitalization. So we want to use this tool to identify people who need more time in home health. But we also want to use this tool to identify people that are ready for discharge so that we know that we can safely discharge them to home. So it'll increase efficiency. I want to mention this last study because I was very grateful to Villanova for the funding for this. This was through a Villanova University summer grant. And what we did was we took all of those data elements that clinicians and patients and caregivers gave us, and we mapped them to the electronic health record at the Visiting Nurse Service of New York. We then extracted the data into an Excel file. We only did about 100 patients. So we wanted to prove to our funder, when we go to the NIH for funding, that we could do this study. So it's called a feasibility study. And we were successfully able to do this last summer. And it's going to be included in my submission to the National Institute of Health, which will be February 5th. So have good thoughts for me that day. Okay? So in moving forward, we continue to systematically build evidence. The clinical decision support tool will be based in the evidence, founded on home health patient, family caregiver, and interprofessional home health experts' recommendations. And I hope that you can see that each study has built upon the previous study to develop a program of research. I want to leave you with what is clinical decision support, because it's very understudied right now, but it is truly emerging. So all of you that are new clinicians, I really feel that as you move through your career, clinical decision support is going to become more and more common. So it provides evidence-based and timely information to inform decisions about healthcare and patient needs. And it helps to lower costs and improve efficiency. Like you see when I said we want to identify people who need more care and also identify people who can be discharged. Okay? So all of this data that is collected, and we previously maybe didn't know what to do with it, we do now. And we are including your data in our clinical decision support tool. So life is a journey, and only you hold the map. Those of you that have been in my office know that that stands front and center on my wall. It is true today, but even more so in the future, that nursing is being shaped by dynamic and innovative nurse leaders. Innovation is not dependent on age nor experience. You cannot possibly be too young, too old, or too inexperienced. So don't say that. I am not buying it. All of you are nurse innovators. We are a globally aging population. These vulnerable older adults need capable, kind, compassionate, and innovative nurses like all of you. Our nation is counting on nurses. The world is counting on nurses. We cannot let them down.